Thank you, Cha. Welcome. Good morning, good afternoon, and good evening, depending on where you are. And I would like to extend a warm welcome to everyone for this first webinar of this year. And this is also, if I remember correctly, it is the 363rd webinar of AeHIN, right since the inception of the webinars. And we are having this webinar on a very important topic. That's the National Health Claims Exchange, which is part of the Ayushman Bharat Digital Mission, which is National Digital Health Mission of India. And then to begin with, we are having one of our working council members, of course, with her colleague, presenting to us, sharing the experience from India. I would like to quickly introduce both of them. The first speaker will be Ms. Manisha Mantri. She's a scientist F and co-investigator at the National Resource Center for Electronic Health Record Standards, Center for Development of Advanced Computing, Pune, based in India. Manisha has over 18 years of experience in research and development in IT. She has led several projects of national importance and has experience in the development of telemedicine solutions, design and development of the nationwide healthcare information store, development of software development kits for health informatics standards, e-health education and training, handling data interoperability issues, developing information security policy for healthcare, extending and developing data standards for country-specific requirements and standardization in Ayush domain. For those who are not aware of Ayush, Ayush is actually a traditional India's traditional and then alternative form of medicine. And Manisha represents C-DAC, also the NRCeS, and as well as India at various international and national standards development bodies, including the International Organization for Standardization ISO, NABH, the National Accreditation Board of India, and the National Health Authority, SNOMED International, Bureau of Indian Standards, HIMSS India, and HL7 India. She currently leads the activities of National Resource Center for Electronic Health Record Standards, supported by the Ministry of Health and Family Welfare, Government of India, in the capacity of Scientist F at the Center for Development of Advanced Computing. Our next speaker is Ms. Sayali Satokar. She's a senior project engineer, again, at Center for Development of Advanced Computing, Pune. With over 17 years of expertise in digital health, she works as a team lead at the National Resource Center for EHR Standards. She is contributing to major national programs such as Ayushman Bharat Digital Mission, ABDM, and the National Health Claims Exchange, driving interoperability and data standardization. She is actively engaged in defining data structures using standards, implementation of electronic health record standards, advisory services, stakeholder capacity building, which advances India's digital health ecosystem. Her professional expertise covers a wide range of health informatics standards, including HL7, DICOM, SNOMED-CT, LOINC, and then ICD. With that, I will hand over the floor to our speakers. And to begin with, it will be Ms. Manisha Mantri. Over to you, Manisha.
Hi, good afternoon, good evening, good morning, everyone out there. Thank you, AeHIN, for this opportunity for me and Sayali to talk about the National Health Claim Exchange initiative that was implemented by the National Health Authority and a small, or I would say crucial, role that was played by NRCeS in development of standards for NHCX. So to start with, let's see the background of how the health claim insurance processing happens and a larger view of it. So first and foremost, when we talk about health claim exchange, we know that it goes through various steps while the claim is being processed. So one is you first do once a patient gets admitted to the hospital for a healthcare service, an eligibility check happens that whether the patient is covered under certain insurance policy. Once that is done, a pre-auth is done if there are procedures which are associated to very, very high costs, and then the approval has been sought before the treatment or before the procedure starts. Then we have something called healthcare service delivery that happens once the pre-auth is done, the patient gets treated, Then once the patient is treated, then the claim submission happens. It happens in two modes. One is cashless, where your payer is directly, provider is directly connected to the payer, or sometimes it is reimbursement claim, where patient pays out of pocket and then does the claim processing. And ultimately, the last step is adjudication and the payment of the claim. So all of this are the general, I would say, high level processes that are involved in health claim processing. Every country would have certain, minor modifications, changes in terms of the process, or the typical information that is sought in every step. So when we kind of looked at the various stats that are available over the web, and kind of we collected some of the information from various sources, and understand that in India particularly, we have the cashless claims processing that happens when the receiving of the all necessary documents from hospital can happen between 3 to 4 hours, and the final settlement typically completes within 24 to 48 hours, which is almost 1 to 2 days. In terms of the cashless claim, and this is the limit that is set by the authorities like IRDAI in India, for that matter. And then the reimbursement claim has a timeline of 30 days once all the required documents are already submitted by the policyholders. So similarly, in Asia Pacific region, standard claims typically takes 2 to 6 weeks or 1 to 4 weeks once all the correct documents are received. And various factors that affect for delays or for taking more time in the processing of the claim include missing documents, uh, uh, that, or maybe the delay in the process. So those all adds up to the time that is taken for insurance claim processing. While in US particularly, the electronic claim are, as of now, fastest, often take processing within 7 to 14 days, while the paper claim takes approximately 30 to 45 days as the state so far. So let's now try and see what are the challenges that we all face. So everyone would have, whoever works in this area of claims processing and the digital health, and even the hospital and healthcare services, would have known of these challenges which are projected on the screen over here, in particularly in the paper-based or hybrid workflows, where you many times have a document lost in between, and because of which the claims get rejected. Many times, you have the separate MRD or the insurance section, where they do manual data entry for claim processing, and that also sometimes leads to error, coding error, or maybe misspell or misinterpretation as well, or even the mapping with the existing insurance claims, where there is no interoperability between the payer's coding system and the provider's data documentation, clinical documentation. So these are few of the errors. However, the further issues are, there are no standardized code available when you want to document the procedures and the medical services that are taken for claim processing, and ultimately the slow adjudication process delays that adds on to high cost. Why high cost? Because more the time it takes for claim processing, more time the patient, more is the patient turnaround time in the hospital. So it is costlier for patient, it is costlier for the hospital, the provider, as well as it involves so much of resource and planning to process such claims, and it just goes on. So the list, the number of claims that are to be processed then piles up at the payer side. So there are multiple issues that comes under. Now the solution is how we digitize and standardize claim processing. So what is desired is to replace this paper or hybrid way of claim processing with structured machine readable transaction. So what it brings interoperability first and foremost, because you start doing structured data entry, you start coding with the terminologies, and the procedures are also coded. Then ultimately you have more efficient code processing of the claims, because you don't have to do duplicate data entry from one system to other system, and an integrated workflow can be visualized if you have standards in between. Ultimately it increases transparency and auditability. You do not lose in between any records. You are able to trace and find out how these claims are being processed, what is the status, what is the level on which the current processing is going on, and ultimately the fraud prevention for the payers. Because they have everything digitized, you can do a lot of data analytics on top of the claims record. And then you and the regulators or governing bodies can come up with new and better schemes which would cater to the needs of end users, needs of the patients ultimately. So many fold benefits, I would say. So this is the current claim settlement process that was in place for India. And I think many of the countries would have the similar status. So what happens is you have multiple insurance companies. Every insurance companies are trying to digitize their claim processing and are at various levels of digitization. So they have their own portals, they have their own coding schemes, they have their own master tables, which they use for claim adjudication, claim processing. So what happens when a beneficiary walks into the insurance with the insurance card at an hospital and gets admitted, the hospital submits a claim. So if there are multiple beneficiaries coming having the insurances for multiple payers, then imagine that the load that the hospital has, where they have to fill claim form many times by hand for many of the insurance company, then scan those and then scan the supporting documents along with this multi and upload this at multiple portals for different patients, for different provider payers, and then track those claims at various portals continuously. So imagine the workload that the provider has, and then the wait time the patient incurs. So the claims are submitted to multiple insurance companies, and then they have their own various processes. So if the insurance companies at a better digitization level, where they expect a manual data entry, but still the data entry happens from hospital, which is done by referring to the clinical documents within the hospital. So the data entry is also duplicated, and then they start putting data, and then those again those gets verified at the insurance companies for their own, in their own way of adjudication. And then there are no clue, even the patients do not have any idea on to which insurance companies where their claims have been processed, if a patient has the policies more than one insurance company. So it becomes a complex structure of managing claim processing in such a scenario. So the challenges here are lack of authenticated data, manual, non-digital or tedious claim adjudication process, non-standardized process amongst insurers, TPAs and providers. Everyone follows their own process, and high cost of processing each claim in terms of time, resources, and the bed that is being occupied by the patient. So the cost. So the solution is National Health Claim Exchange. This enables a unified, the idea of NHCX is to make a unified, trusted national digital claim ecosystem by standardizing and securely connecting all the providers, payers, and patients and regulator for end-to-end paperless claim processing. So this project's a single exchange platform, health claim exchange platform. It is completely standard driven architecture. It supports end-to-end digital workflow of the whole claim processing. And then it is vendor or payer neutral. So there are no, the way the health claim exchange platform is built, it is agnostic of any platform, any technology, or any vendor particularly. So the open APIs allows any payer or provider, or for that matter, any digital IT service provider, to develop softwares on top of this whole platform, NHCX platform. This has been developed under Ayushman Bharat Digital Mission by the National Health Authority in consultation with Insurance Regulatory and Development Authority of India, IRDAI. So I will use these jargons, ABDM, NHA, and IRDAI in further presentation, along with me, Sayali, as well. So this is how the after implementation of NHCX, this is how the simplified claim settlement process looks like. So the digital KYC of patient happens through the unique health identifier of the patient. In India, we call it ABHA. It's Ayushman Bharat Health Account. So a health account number is provided to every patient. So the patient is being onboarded to the patient registry of the platform. Then the hospital, when submits a claim, has to only follow open APIs, which are provided or which are being published by through the National Health Claim Exchange. And on this open API, the data goes is in the form of common claim standard data objects, and which are nothing but the FHIR data structures, which can be used across any hospitals or any payers as well as providers, whether they are government or private. And these FHIR objects have been standardized and defined with multiple stakeholder consultations across, with the policy bodies, with NRCeS, NHA, and payers and providers getting involved, with the multiple rounds of consultation, with multiple rounds of corrections. The objects have been standardized and now are available for the exchange. And then this data travels over the National Health Claim Exchange platform, where any insurance company can onboard to these open API. They can validate the metadata. For example, who is the center, and the exchange itself does this validation, who is the sender and who is the receiver of this information. And then the exchange routes this information to the insurance companies, whoever is the receiver. And then once the routed information is received by the insurance companies or the payers, they then can adjudicate the claim. So overall, the platform helps you to make sure all the digitally verified forms are submitted. Auto adjudication is possible with few manual adjudication in the cases required with the same platform, and everyone is onboarded on the common standardized and structured APIs and data structures. So that's the aim of NHCX. So coming on to NHCX, this has been derived from the digital public good created by the development community in India, and is being now authored by National Health Authority, Ministry of Health and Family Welfare, Government of India. This initiative is part of the recommendation of JWG of IRDAI and NHA, and the aim was ultimately to enable standardized and faster claim processing for better patient experience and reduce operational cost related to claim processing. So that's the ultimate aim of NHCX, and NHCX has standardization and interoperability built in. They have seamless data exchange, exchange of documents, images between any payer and provider, completely FHIR compliant e-claim formats through single gateway using standard protocols have been utilized. enable transparent and efficient claim processing, and then ultimately it aims to reduce operational costs related to claim processing. These are the stakeholders who are involved in NHCX and their proposed benefits. So we have payers, including state health agencies, insurance companies, TPAs. We have providers like hospitals, clinics, diagnostic chains, labs, and pharmacies, insured persons, and which includes all the policyholders like patients, and then PMJ. It's one of the government scheme for national health insurance scheme, all the beneficiaries under that scheme, and then the policy and governance bodies including NHA, IRDAI, and Insurance Information Bureau of India, IIB. So the benefits I think we have talked about. For patients, it's first and foremost is reducing wait time. For providers, they get a single payer network, universal claim format, which reduces their burden of claim processing, and they get better visibility of the claim process, and then also offer improved patient experience. For payers, they have reduction in the overhead operational costs. They again go with the paperless operations, whoever as possible, and then the better quality of data for industry and regulator. They can submit all the information collated at one place in single format to the regulatory bodies and authorities. And ultimately for policy and governance, one single national view of claims data across the scheme, states, and provider. Simplified compliance reporting, I think, is the first and foremost important part. And then also the information and the data collected can even help regulatory body to give more insights onto coming up with more schemes which are required for the uh, healthcare and the benefits of the society. So that's, I think, are few of the benefits proposed. How do we start with NHCX? What is it all about? So NHCX is all about onboarding the providers and payers. And this onboarding, it takes place in two steps. It's a two-step process. One is to ensure that any payer or provider who is onboarded to NHCX platform has completed all the steps required for getting onto the platform. And then second is going live. So the first step involves the whole sandbox testing and certification, where a payer or a provider can register, or a software vendor who has developed the software for that particular payer or provider can onboard. Then they do the API integration, they do the testing, and then ultimately a sandbox certification happens. Once the certification happens, they can go live on NHCX, and they will be provided with a unique participation ID and production access with the secret key and the credentials to work on the secure network for data exchange. So these are the two simple onboarding process. And what all things are there on the platform? So the platform serves as actually as a central routing engine for managing of the flow of the data between healthcare provider and other NHCX participants like payers. And then it receives, validates, and processes data by ensuring that it meets the minimum requirement for format and the security. So key building block of NHCX are exchange protocol, message structure, and API structure, and error handling. All of them use one or the other standards to ensure everything is understood and anyone can adopt them. So open standards, so RFC 7516 based exchange protocol, file structure and format for message structure, RESTful APIs, and ultimately standard error handling. So all of it involves NHCX. So the technical specification is also available for reference to any implementers out there. And the specification is open, so anyone in India who has a software for payer or provider can onboard on NHCX without any cost, provided they follow all the steps of verification. So these are the key use cases of NHCX. In NHCX, coverage eligibility, pre-authorization, claim, payment, communication, and reprocessing. So all of these workflows have been taken care of. The standards, coming on to the standards part. So inclusion of health informatics standards in NHCX covers the basic structure as FHIR, HL7 FHIR R4 artifact structure, then SNOMED, LOINC, and ICD for data coding, and DICOM for the attachment of medical images. One of the real world example I would like to emphasize here for all of you is the PMJY. It's the world's largest public health insurance scheme floated by the government of India, which is called Ayushman Bharat Prime Minister Jan Arogya Yojana. It's PMJAY. And it kind of aims to provide health insurance of up to 100,000 Indian rupees to each eligible household annually. It serves as live large-scale reference implementation of NHCX in the country. So the PMJY covers medical examination, pre-hospitalization, surgeries, procedure, diagnostic, ICU charges, and everything, even the post-hospitalization. And it is portable, so you can go any part of the country and avail this scheme. So you imagine the scale of implementation of PMJ, and it uses NHCX as a backbone for data sharing. So PMJ, to tell you the stats, show over 420 million cards have been created under this scheme, and almost 120 million families have been, have utilized the scheme's benefit to reduce the out-of-pocket expenditure. So this is where the scheme stands in, and the scheme covers the secondary and the tertiary care as well. So in India, the care levels, so the healthcare facilities are divided at three levels. Primary care, where basic medical care is provided, particularly for preventive and treatment of common diseases. Then you have secondary care, where district hospitals or sub-district hospital or community health centers are placed. And then ultimately the tertiary care, where specialty hospitals, where for specific health conditions or complex health condition requiring expert medical knowledge, are being placed, like medical colleges or state level institutions. So the scheme works at all the level, and that's where the scale of the scheme is. So NHCX has been implemented in this scheme. So before I give it to Sayali to talk in more detail about the structure, I will quickly walk you through about the National Resource Center. So we are the Center of Excellence at Ministry of Health and Family Welfare. We work with national bodies, we work with standard development organization, we create Indian standards, we customize standard as per national requirement. We even help in adoption of global standards in the country through training, education, tools, technologies, and so on. Few of the services of NRCeS as noted here, and some of the stats. So we are connected with almost 1,085 health organizations, health and health IT organizations in the country, and we have sensitized over about now 30,000 healthcare professionals and health IT professionals in the country. So I will now hand it over to Sayali for quick kind of providing a quick walkthrough on how the NHCX integrated infrastructure looks like. Sayali, over to you.
Yes. Thank you, Manisha, and thank you again for the opportunity and the introduction. So I'll continue with the remaining part of the presentation, where I will cover how this infrastructure is, working in an integrated way. So there are two aspects of it. So one, where there is an infrastructure or a base infrastructure which is provided by ABDM, which ensures the trust, governance, identities with the help of multiple national registries for a patient, for healthcare professionals. Then it also ensures the consent with the consent management thing in it, and it also ensures the policy enforcement across the health ecosystem. So ABDM infrastructures provides that, and on top of it, internally, the FHIR ensures the health and claim data to be consistent, to be interoperable, and it can be reused across the system. So whatever is happening, whatever data that is getting exchanged in the infrastructure follows a specific structure which is based on the FHIR, and together this infrastructure makes an ecosystem which is which gives you the integrated digital health infrastructure of a country. While designing, being a national standard body or center of excellence body for EHR standards, so we have designed this FHIR artifacts, how this data should be structured with the help of FHIR. So we have our design considerations. So when we talk about the health claim processing, it involves some kind of submission of or some kind of request which needs to be processed, which needs to be handled, and some kind of a response for that process. So in claim processing, it involves exchange of data, different documents, even images between payers and providers. So design considerations that we have taken is we need to map a claim workflow, where request response is there, to the FHIR model. Okay, so considering this design consideration to reduce the complete operational cost of claim processing, and that enables efficient claim processing, we have particularly designed FHIR bundle for each of the process, or for each of the steps, for each of the use cases. So now consider one of the important workflow where it involves a claim submission. So for a claim submission, you have a standard claim form. What it involves actually physical documents. Okay, so that to support that claim, what all services are provided, other things that can be supported by the lab reports, by discharge summary. Okay, all these things. So in order to make this complete package as a data to be exchanged between payer and provider, we have designed FHIR profiles for each of the thing, which will takes care of all this data together in a bundle. So for that, we have designed and posted FHIR implementation guide for Ayushman Bharat Digital Mission, which is available at the nrcs.in/ndhm. So for specifically for the NHCX National Health Claim Process, we have this 6 claim records, which internally supports the claim processing flow, and we also have in the same implementation guide some of the ABDM profile that you can see on the screen, which actually gives you the record artifact view, which has actual document that patient carries for the continuum of care when it gets transferred to multiple care providers. So that records can be further utilized while claim processing. So everything here is interrelated, and it is interoperable. So these record artifacts can act as a supporting documents in the claim submission process. So we have this implementation guide posted at this site that you can have a look, and these are the artifacts that we have currently designed for both ABDM and NHCX. Now, when we talk about profiles in detail, how we are designing it for so considering the NHCX use case, there are multiple stages that we have thought of. So there is a claim submission, and throughout that process, there are multiple communications happens in between. So there is a communication to request for some more supporting document. There is some queries are there. So this is to and fro information is flowing, and consider so record artifacts in the form of FHIR bundle is designed by looking at each of this aspect. So for claim submission, there will be a claim bundle which takes care of the use cases like pre-auth and final claim submission, which encapsulate information related to process each claim pre-authorization and claim submission workflow. Then there is a eligibility request bundle, which takes care of the bundle takes care of the data required to process that request. And there is a task bundle, which is involved in multiple use cases. Like I said before, there is a communication happened during this processing thing to request for some more documents and queries. So for that, with the help of task bundle, with the help of its elements like input and output, by providing correct information in it, the receiving entity can execute that task and again gives it back give back the response to the asked information like user who is requesting that information. Similarly, we have an insurance bundle which actually reflects what insurance plan is, what exactly it covers. So for that, there is a insurance bundle that is planned. So this is how we have designed our artifacts, which are based on FHIR, and it is in the form of FHIR bundle resource. It is based on the bundle resource. So when you look at the detail, the technical part when it comes for FHIR, so how we have designed, so there is a claim bundle, and that bundle is of type collection, where when we look at the scenario where we are creating a claim submission flow, and for that, the underlying bundle is a claim bundle which requires claim resource to be mandatory. So here, whatever that claim resource refers to the other resources that comes under in that bundle in order to form a complete information encapsulated in a bundle. So this bundle gives you the syntactic interoperability, and each resource then further refers to the, whenever there is a clinical terminology is used in the resources, we are using SNOMED city or ICD, or for that matter, LOIN codes. You can see here the condition and the procedure resources refers to the specific coding terminology, code systems, and that's how we here achieve the semantic interoperability. So that is why the complete interoperability, when you think of the complete interoperability, we are getting it through coding system, and a specific structure that we are following is the FHIR. So this is how our bundles or health claim exchange data structures looks like. So as I told you before, so there are two aspects of it. So when we talk about the NHCX engine, it has API infrastructure. Now, under each and so for each use case, there is an API, underlying API, and the data structure it follows. So like for coverage eligibility, the endpoint will be this, and there is a flow that is going from, or provider is requesting to a payer, or payer is requesting to a provider, or sends back information in the form of response. Depending on the each use case, there is an underlying bundle that is designated for that APIs, and that API is supposed to carry that bundle and give it to the target entity that it is requesting. So there are use cases. So request additional attachments, where in between claim processing, if a payer feels that some more things are required, some more documents are required to support to process that claim. So that for that use case also, there is a communication API which follows the task bundle. With the help of elements in it, they can have a perfectly structured query on what is asked and what is requested to process that data. So there are all of these use cases are there. Similarly, there are search and reprocess and check status APIs are also there, which actually searches, which are actually used by the authorities, can be used depending on the requirement they want to get about it, about the complete process, and status is checked. So these are all the APIs that are available here. And if the time permits, I can take you through the shall I take you through the the complete IG. Let me take you. Yeah, let me share the screen now. So this is the IG available, and here are API. Here are profiles for ABDM, which gives you the structure of document artifacts, HI types, we say, and this is the NHCX profiles, which provides you the FHIR profiles required for the health claim exchange. So when you look at the claim bundle, you see in a differential view for a claim bundle, we have a fixed type called collection, and for a claim bundle, claim is has to be there. We made it mandatory, and internally, claim profile is being profiled. Claim resource is being profiled according to the need that is required to be fulfilled to process that claims. Like we have must supported the supporting information. We need to have a diagnosis required to process. We need to know the diagnosis required, diagnosis for the processing that claim, and item the services that are provided in terms of items where actual product and services will be listed. So, and in claim response, we will have all the adjudication in that claim. And for each resources, just for each of this claims and things, we have given a set of examples as well. So whenever a claim response, for that matter, bundle, when it comes to enhancement, how response should be prepared, so we have number of envisaged examples or use cases that we thought of, and for that we have created examples. So that is all available, and that covers the part of the presentation from my side. If anything else, Manisha, we wanted to share.
No, I think we are good. Over to you, Cha. If there are any questions, we will be really happy to answer and provide information. Thank you, Alvin. Yes.
I have a couple of questions. Maybe I will begin with Manisha. And then I do see some questions already in the chat also, so we will take them. We still have time. What's next in the National Health Claims Exchange is something that I would like to ask. Is there a roadmap of what is to come next? And then, are you using Fire Standard for anything else apart from, of course, Claims Exchange? And then, are there any challenges, especially that you are facing while designing or picking standards for the Claims Exchange? Those are the questions from me. Thank you. Over to you.
Sure. So I'll take the first question. What's next in NHCX? So as you saw, so far the NHCX whole platform is ready. The claims structures are also published, and all we have almost 42 payers onboarded on NHCX, but the pay providers are getting onboarded. With more time, we will have more adoption. So adoption is the next step. And then when we say adoption, we will have the continuous hand holding and then revision of the structure. So many comments will come, many of the problems would be identified, the implementation level challenges more and more will be identified, and those have to be handled. That's the first step, I think, next going forward. And second is the one use case that we are trying to work on is how can we also promote or how can we include the use case of reimbursement claims. So we have in Ayushman Bharat Digital Mission, we have unique patient health identifiers. So patient can have their own personal health record, digital health record lockers, and then if they have all of these data collected, can they also use the same claims exchange platform for claim processing for reimbursement claims? So that's the next use case that we're trying to see, because on NHCX platform currently payers and providers are there, so we have limited participation. So scaling it to 1.5 billion if we want to say even not like at least 0.5 billion for that matter, if we want to scale it to that level, how do we take care of? So that's more and on the performance side for the claims exchange protocol and the platform, which is more like NHA's forte, but we will have to take care of the use cases, how these claim processing will happen in terms of the reimbursement claims. So that's the, I would say, the next things in NHCX. And you had the next question on have we used Fire for something else also? So Fire, I think 4.0 has been now a core standard for India, where we are using it for Ayushman Bharat Digital Mission, where we want to digitize the whole healthcare data sharing process. So whenever a patient goes from one hospital to other hospital, the data shared from hospital has to happen through digital highway, which is ABDM highway, and that data is packeted in Fire documents. So we in ABDM we have adopted Fire as a document architecture standard. And apart from that, we are also trying to explore if we can use it for creating Indian version of IPS, International Patient Summary. So IPS is one thing that needs to be taken care of. We have medical value tourism is also one of the biggest thing. So how do we share data which is internationally also acceptable and adopted? So for that, we are trying to explore as of now Fire as a standard. And coming on to the third question on challenges, particularly on designing NHCX. So on the challenges part, I think the major Herculean task was to make sure all the services, all the procedures that are noted by multiple payers are being taken care of when we want to code the product or service codes in the claim object. And that was a massive task, just looking at so many masters and then trying to map them and then also map it to a standard which is acceptable. So in SNOMED, for example, those who know SNOMED, it's a clinical terminology and it has multiple hierarchies. But services like, so procedures can be very well covered, or diseases can be covered for disease packages. But for services like ICU, or you have taken an air conditioning room or an executive room, which has different rates when you want to process the claim, you can't code them. That's not part of clinical terminology. So we had multiple rounds of discussion, and that still remain a gray area for us to explore more. So these are certain gaps, I would say, and design challenges that we had. And also trying to use specific resources in Fire which had very low usage. So their implementability was very, very low. Not all or not at many places the resources were used. So the implementation guide for those resources was also limited, having a very broad and a raw statement, and then trying to decipher, then trying to get expert knowledge or trying to get hold on the experts from HL7 International to understand what does it actually mean and how do we utilize them itself was I think was a task. So my team, Sayali, and my team at NRCeS, they had done a very well, I mean, very good job. That's what I would say when we are now at a very good state with the claims object out there. So I think this, Sayali, you want to add anything?
Nothing. Everything is covered, Manisha. Thank you.
Okay.
Thank you, Manisha. This is very helpful. And then you answered, I think, not only my question, I think a couple of questions also. I think there was one related to SNOMED. I think you covered that. And then also reiterated something that we discussed yesterday. Maybe the next one of the next topics that we could take up in our AeHIN hour is the IPS experience from India. So you did also allude to that. So I think it's time for us to also reach out to the colleagues in NHA, and then of course again to you for maybe having the webinar on that. I think we should take a couple of at least other questions before we close. Cha.
Yes, thank you, Sir Jai. We have a new question here from Sir Titus. So while processing these claims, do you store PII records, or does the NHCX just act like an interswitch where it only pass communication without retaining health records?
Yeah, so NHCX acts as a gateway. It doesn't open the packet, it doesn't decipher the data. It just opens the header where it wants to know who is the sender and who is the receiver, and whether the packet is being structured correctly or not. So the basic checks and the basic security checks. After that, it just gives it back to the receiver. So yes, it doesn't read the data, because the
Yes, thank
communication
you,
has to be
Manisha.
secured between the payer and the provider.
Our next question is from Dr. Rushikesh. Any software vendors onboarded already? How do you rank them or recommend them to hospitals and payers?
So there are many software vendors onboarded. So NHA has its own website where it provides the list of certified vendors, particularly for health claim exchange. That's an open website. So Rishikesh, you can refer them, because NRCeS is a more towards standard development body, and we support adoption of standard. As such, we do not keep track of who is done and to what level. We do not certify. So there is a separate body which works on some certification and compliance, particularly for the APIs part. The standards part, we do help them verify and validate. So if you ask me if I want to rank them and recommend them, I think anyone who has implemented NHCX and have certification of the M3 compliance, they are the softwares which can be utilized, but they have their own different features. Even the feature lists are also provided at NHA's website. So I recommend you to please go through those lists. It will be helpful for you to even choose and select one which suits more to the hospital based on the features.
Thank you, Miss Manisha. We have 1 minute left for the session, but we still have a number of questions in the chat box.
I think we're at the top of the hour, and I think we should give time also for the others to rest. But I'd like to congratulate and thank Manisha and Sayali for sharing their experience. We learned a lot. Maybe we can ask them to answer the questions offline and share it with the community. Thank you, Manisha. Thank you, Sayali.
Thank you so much,
Thank you
Alvin.
so much.
Thank you, Manisha. Thank you, Sayali, for joining us for the first AeHIN Hour webinar in this new year, and then also your experience sharing, such a large implementation, how a national NRCeS as the National Center of Excellence established under the Ministry of Health to support the adoption and implementation of electronic health record standards is able to actually support a national project like this, or means I wouldn't say the project, it's a national program like this. So this is, I think this is also a lesson that how an institution like this can actually help the national digital health programs in other countries. That's how I would like to actually conclude, and then maybe we can have a group picture.
All right. Thank you, everyone. Thanks for joining.
Thank you everyone, and thank you,
Thank you.
Jay, Alvin, and
Thank
team for
you.
having
Good
me
night.
here, having us
Thank
here.
you.
Thank you.
Thank
Bye.
you, everyone.
Thank you all.